Good day, everyone. My name is Matt Smith, and I'm the Director of Training at Corvell Corporation. I'd like to welcome you all to our webinar. Our subject today is COVID-19 claims, and in the next hour, we hope to shed some light on some things that we have learned despite so much that is still unknown in the present climate. I'd like to introduce Diane Blaha, our Chief Marketing Officer, and Melissa Storin, our Vice President of Marketing, who will be monitoring the Q&A pane, which you'll see in the lower right corner of the WebEx screen. We encourage everyone to submit questions throughout the call, and we're going to leave some time at the end of the session to address the questions that we receive. I'd also like to let everybody know that the audience lines are muted, and we are recording today's call, and we'll make a link to the recording available to everyone who registered at the end of after the meeting. It's my privilege to welcome our speakers for today. Dave Brown has been with Corvell since 2005. He's Corvell's Chief Claims Officer, and he serves as our product manager for TPA services. He's a certified marketing executive, casualty claim law associate, and a speaker at many industry events. Michelle Tucker, Corvell Vice President of Claims Operation, and she's been with Corvell since 2009. Michelle has over 30 years of claims management experience, and she's responsible for the technical and quality oversight of claims operations nationally. And Karen Thomas is the Director of Case Management Innovation at Corvell. Has been 19 years in several different capacities, including a field case manager, the management of our case management team in the DC metro area, and then she managed our 24/7 nurse triage operations. Karen is a clinical nurse specialist with more than 30 years of nursing experience, including clinical, consulting, business, and operational management. Karen was also a university educator for nursing and healthcare majors and has published articles on healthcare and case management topics. And so I would like to now introduce Dave Brown, and we'll begin our session.
Thank you, Matt, and thanks to everyone on this call for your participation. You know, it's hard to believe that as recently as just a month ago, in early March, it was mostly business as usual. And with a suddenness that is difficult to comprehend, the world changed at every level of human endeavor. The headlines seem like they are from various science fiction movies, and not good ones at that. Here is just one stark reminder of how quickly what we believe to be true in life and predictable in the insurance industry is anything but predictable. Some of you may have recognized this building in the image by now. Many of you have been there. You see, the hospital in this image is actually the McCormick Center, the Chicago venue for the next Workers' Comp and Disability Conference. Today, it is a hospital ready to handle expected overflow from conventional facilities. We know this can be overwhelming. But as industry professionals, all of us are now the first responders in the effective management of the claims that we see are beginning to flow. So today, I will provide a short overview of what we see in the numbers, while Michelle and Karen will follow with the insights and tools we are applying. Because this is unlike anything we have seen in the history of claims, the true development of COVID-19 claims will take years to know with any certainty. Although it is still early, we thought it would help to summarize the scope of claims we are receiving, and it shouldn't be a surprise that our numbers align well with public information in some cases, but for good reason, they are way off in others. So let's start with where we're seeing the highest level of occupations, and that should be no surprise. It's all coming from first responders and healthcare. More than 90% of our claims are in those two categories, with a significant amount coming from retail and food service, groceries, etc. We have a wide base of clients. This is just a function of the nature of the disease and who's out there and exposed to it. And something that no than the week before. In fact, last week was the 6th straight increase in overall reports. And last week, so the trend seemed to be growing. In fact, in more than 30 states last week, the trend ramped up in a week-over-week comparison. We don't know exactly when the curve is going to flatten for the workers' comp space, but when it does, it generally seems to happen within a week or two of when the claims reach their peak. So hopefully we'll be getting through this in the next couple of weeks. Another trend that we're seeing is an increasing lag in the days it takes from when exposure happens to when we're able to act on the claim. So the chart you're looking at, starting at the left, is back in March when we began measuring it through last week, with now a 15.5-day average lag time from exposure to when someone begins working on the claim. And although efforts are being made, we know that many are still waiting for testing, and testing is definitely causing some of this delay. We think testing is going to be a temporary effect. A number of facilities are now beginning to look for private source options because they weren't able to get testing quickly enough from government programs. And creativity is taking hold. Dentists are being asked to turn their offices into swab manufacturing using their 3D dental mold printers to help break the bottlenecks in testing. So we're hopeful that these efforts on multiple fronts will help the situation. However, our data is also suggesting that in some cases, companies are not reporting the claims for as much as 3 to 4 days from when they first hear about them. And COVID is no different than any other claim. Earliest reporting means earliest intervention. And the sooner we can get into the claim and get working on it, the more quickly we'll be able to help those that are struggling and are feeling challenged and overwhelmed by this disease. So fortunately, Corvell's work with an extensive number of these claims has already helped us find innovative solutions that bring hope to those we serve. It is my pleasure to turn this over to Michelle Tucker, who will speak to our perspective on the management of COVID claims. Michelle?
Thank you, Dave. Appreciate that. I also just wanted to take a second to thank the many folks on the call who have submitted questions to us for today, and we will certainly try and answer as many of those as we can as we walk through what we know. Certainly the majority of the questions we received relate to the determination of compensability for workers' comp claims. So I thought I would start today by just spending a few minutes talking about some of the key areas we look at in determining compensability and some of the things that we've learned over the past several weeks as we've continued to receive workers' comp claims involving COVID. Certainly we know this is a very case-by-case analysis. It involves a very thorough collection of information, especially as we're starting to see increasing litigation related to COVID-19 claims, and I'll speak to what that looks like later. But really what is most important here is the details. The collection and recording of details will be key as we move forward through assessing compensability and ultimately dealing with litigation related to COVID-19 and workers' comp. So let's start at the beginning and where you start when you receive one of these claims. And it really starts with a very prompt, compassionate collection of information from the injured worker. And I think it's important to recognize that injured workers are dealing with really varying levels of this illness. When the claim is reported, they're worried about themselves, their families, their jobs. So while it's important to gather information and be complete, it's also important to do so with care and empathy and understanding because these folks are really in a different place than they've ever been. It's also important to do so promptly. We know through published reports that there can be significant worsening of symptoms very quickly with this disease. So prompt and compassionate collection of information is so very important. And certainly the collection of information such as non-work related activities or other exposures is important as well. Particularly in the healthcare sector, we see folks working multiple jobs, so we need to have an awareness about other exposures, anyone in the home having the disease, et cetera. Again, we talk about details. That's the level of details of information we really need to collect. And one of the things we've learned over the past several weeks is that it's important to outline a very clear timeline. And by that, I mean documenting when the alleged or confirmed exposure occurred, if it's known, and in some cases it's not always clearly known, when symptoms developed, when were the first symptoms and what were the first symptoms, was the injured worker promptly quarantined, and for what period of time? Have they undergone testing, which, as Dave mentioned, is a challenge, and I'll speak to that later. And then certainly if there's been a diagnosis. We know in well-published information from the CDC, the development of symptoms relative to exposure is generally 2 to 14 days. And while that's certainly not 100% conclusive, it is reliable enough to be able to use your timeline to determine if there's further medical investigation needed regarding causation, certainly exposure to disease. I think that's an important detail to acknowledge. Next, we all know this is a very dynamic and changing environment in regards to work duties. Employees are doing very different jobs currently. So maybe completely different than they were hired to do. A couple of examples, certainly we've seen restaurant servers who have now become delivery drivers. You may have a truck driver whose route has deviated and they're now delivering medical supplies to a COVID triage center that's been set up outside of the hospital. So working through with the injured worker to collect very specific details about their current work duties and their work practices. Where have you been? Where do you believe you've been exposed, or if you know you've been exposed, is an important detail in determining whether or not a claim may be compensable. The example I gave with the restaurant worker who became a delivery driver actually had delivered food to a senior care facility who the next day publicly announced a very large outbreak. So details such as that are such an important component of determining compensability during this time. And certainly following that with a thorough discussion with the employer. We want to know what the injured worker was directed to do, the expectations of their current job duties, to make sure that we don't have a situation of deviation. And again, that can complicate the compensability decision and certainly create further issues that have to be investigated. The medical diagnosis or analysis of the disease is important. Do you actually have an injury? Has there been a positive test, or is this an assumed situation of the disease, which is occurring in many situations with medical practitioners? Dave mentioned testing continues to be a challenge. Complicating that, we're still seeing lagging result turnaround times, still some lack of supplies in some states, and in some situations, just the basic availability of a test based on symptoms. Some folks are trying to get a test, and because they're not sick enough to be hospitalized, they're being asked to self-monitor and are not being allowed to obtain a test or participate in testing. And so that has been a complicating factor for many of these claims, unfortunately. The other issue is we are still seeing continuing a large percentage of false negative results. We've seen percentages somewhere between 30 and 50%. That complicates the situation because you may have someone test negative and then hours or days later they're having to be retested because of worsening of symptoms and then an ultimate diagnosis of the disease. And how that falls in your timeline is, again, very important in the analysis of compensability. And then lastly is the legal analysis, which includes jurisdictional analysis. I think all the folks on this phone know through the wealth of information we're getting related to COVID that many, many states are expanding presumptions, changing the rules in the way we apply occupational disease rules in many states. However, most states have had very long-standing conditions of occupational disease. You may have heard to this as heard of this as called peculiar risk. And that's a term you may have heard of in regards to occupational disease across many states. And basically what that means is, does the risk of the job create a material greater risk than the general public would be exposed to? And you can see why that type of threshold regarding compensability makes it just so very important to collect and document current job duties and responsibilities and what an employee has been doing during the time that they may have been exposed or may have been at risk of exposure. We know that many states also have established case law regarding occupational disease, so it's important as you do an analysis of compensability to talk with your employers and potentially meet with defense counsel or carriers in regards to discussion of compensability related to the threshold of peculiar risk. So that's kind of in a nutshell, just a quick synopsis of compensability. Again, the devil is in the details, as they say. And I'm going to move now to kind of the second level of volume of questions we received, which is, how are states officially addressing COVID-19? And we've shared a chart on the slide here that shows you really the depth and the volume of legislation related to COVID-19 across the country. Currently, there are thousands, and by that, officially there are thousands of legislative changes being adopted or proposed or are pending currently. We've seen them be very broad and interesting. Alabama has adopted legislation urging a fist bump over handshakes. Certainly, we've seen wide recognition of the use of telehealth and virtual health care, and then also some adopted and pending legislation in states which are extending statutes of limitations, some with a relatively open-ended date currently. So I think that's a dynamic we're going to continue to be interested in. About 30 states right now have adopted or are in the process of adopting COVID-19 legislation specifically related to insurance and claims. And for workers' comp, we're seeing changes range from states like Kentucky, who have included not only certainly the frontline providers and first responders, but have expanded some of their presumption coverage to include grocery workers, daycare employees. And looking at the legislation reference on the map that we sent over, certainly some of the national COVID hotspots we've seen, such as New York and Louisiana, have already passed or have pending additional COVID legislation. What is interesting to me, and I physically sit in California and have spent a lot of my career here handling claims, is that California has been somewhat slow in adopting COVID-19 legislation. There are currently a couple of pieces of legislation pending in California, but again, somewhat surprising in regards to their limitations and coverage. I think the most talked about currently is expanding what the definition of an injury is to include COVID-19 for frontline providers and first responders. It basically creates somewhat of a conclusive presumption and also includes, interestingly, a component for things like the reimbursements of temporary housing costs that they may incur because of quarantine or reimbursements of PPE costs. So I think, again, that's pending. We'll continue to watch it, and certainly we'll share that information. Corvell has established a legislative map located at corvell.com, and we will continue to feed information and links to states information as we receive it, so those on the call can access that and see in real time what we're seeing as well. And certainly we've seen states like Illinois who adopted expanded presumption rules, but because of a lawsuit that was filed there from, I believe, a trade organization, that has now been suspended, and there will be further legislative review in Illinois the first week of May. I think we can expect to see that in multiple other states as well. We are seeing also an increasing number of states who have adopted or currently have pending legislation regarding expanded loss of use or business interruption coverage, and that would be to include coverage of claims related to COVID-19. What's interesting is that some of these states are disregarding endorsements or exclusions that specifically address virus or pandemics, or don't include some clear definitions regarding what is considered damage related to COVID-19. And I'll talk later a little bit about litigation, but certainly there are some significant issues of the ability for some insurers to be financially able to pay these if we continue to see these expanded coverages, both from a presumption standpoint and from language in the policy being disregarded. So I think, again, we are just at the cusp now of really what we're going to be seeing in regards to litigation. A little bit about emerging trends. Lots of questions about what we expect to see or what we are already seeing. We are beginning to see a very well-developing cottage industry regarding COVID-19 litigation. And by that, you're starting to see communications being sent out by attorney groups, maybe a couple billboards here and there. It certainly has been slow to develop. I think a lot of attorneys are, and others in the public are really looking at what avenues they may have from a litigation standpoint. We know that litigation related to COVID-19 is going to stretch for decades. The size of this and the depth of this disease is dramatic. There is a predicted tsunami of litigation coming that will develop over a period of years. Estimates that I've seen from a number of sources indicate costs related directly to just to litigation. So this does not include the cost of the loss here or any resulting settlement payments, et cetera, but expected to be in the trillions of dollars, which is, as you can imagine, extremely significant. We know through some conversations and again, published information, several large carriers, trade and business groups have either already filed or have indicated they will be filing lawsuits or injunctions to block some of the state regulations that have been adopted, either for the expanded benefits or presumptions, or again, the mandatory coverage situations. And we've seen that be at least temporarily successful, as I mentioned earlier, in Illinois. We'll continue to monitor that. But again, I think you're going to see a pretty significant rise in litigation related broadly to the adoption of this legislation. One of the things that's specifically concerning to me because of my work comp background and certainly from many of the folks that we work with in this industry is the rise in civil lawsuits that we're starting to see. And these would be filed by employees or the families of employees or groups of employees, frankly. We've seen a couple class action suits be in the works alleging employer negligence. And many of these actions outline causes of action such as intentional misconduct by employers for a failure to close their business or to provide proper education and PPE. Some allegations of failing to screen employees who may still be essential workers and required to work, and certainly the enforcement of social distancing. I think we're going to see some challenges here in regards to exclusive remedy rules in many states. And this is going to be a major concern as companies across the country start to look at what's necessary to be prepared for reopening. And that's not a topic of today's call, certainly, but it is an area that I would provide some importance to for those of you who are looking forward to reopening your business and being prepared with a really comprehensive plan to do so. We are seeing some insureds, as I mentioned, file suit regarding denial of coverage. Lots of claims being presented for reimbursement of costs related to the disinfection of work sites. And as you can imagine, the demand for that is increasing, especially as we start to look at reopening. We're going to see a lot more demand for that kind of service. And for some of these employers, the cost of that can be extremely expensive. So I think we're going to continue to see some litigation there. And, you know, again, insurers are going to have to look to perhaps litigation to resolve that moving forward. So from a primary litigation standpoint, that's generally what we're seeing from trends. And again, we'll continue to monitor that. On the claim side, unfortunately, and not unexpectedly, one of the more rapidly developing trends is unfortunately mental health claims. And again, I don't think that's surprising to anyone. Again, it's been somewhat slow to develop. Folks have been on the front line and just really engaged in the work that's required of them. But unfortunately, it's taking a toll on many of our frontline health providers specifically. So we're starting to see some PTSD claims, mental health claims, some psychiatric disorders. We know by history that these sometimes could take years to develop. So that's a consideration as well. I think we're going to continue to see these claims moving forward. I certainly think to help manage this, a well-published EAP, certainly the access to mental health support, either through telehealth options, which Corvell does have available as well certainly for your use. The consideration of on-site counselors, if you have a large group of employees who may be engaged again in very stressful or tense working situations, would be a consideration. And I think, again, from a claims perspective, we continue to work with our case managers to really assess and try and get in front of these mental health issues. It's both a coping related to COVID-19 or maybe just, quite honestly, a standalone situation. So recognizing that is extremely important. We're also seeing a rise in injuries related to remote work sites. Of course, like most folks across the country, many employees are working remotely now, and it's difficult for an employer to continually assess the safety of a home working environment or remote working environment. It's difficult to determine ergonomic needs. Certainly we have employees who are working longer hours maybe than they have historically. So again, it's important to regularly engage with these employees who are certainly working hard, working remotely, to keep them engaged so they're not isolated, have conversations about worksite needs, ergonomic devices. We have a couple of our customers who are doing daily Zoom exercises, ergonomic exercises with their folks who are working remotely, and to promote, good ergonomic and exercises, worksite exercises at home. And then also, we have some folks who are doing Zoom or virtual ergonomic assessments at home. And I would say that's one thing to consider, especially the longer this goes, if we're going to be working longer hours or more periods of time from home. So we'll continue to report on that. Most of those have been cumulative trauma in nature. We do occasionally get an unusual tripping over a dog in the house. We actually had a claim for an employee working from home who was exposed to COVID in the home. So those are maybe some of the more unusual situations. So let's talk about managing information. I think we all know it's just a constant flood of COVID-19 information. It can be very overwhelming, and it's very rapidly developing. Probably by the time I get off this call, there will be 2 to 5 very urgent broad developments that we're going to need to look at universally for the country. From a claims perspective, this is a time that claims professionals really have to utilize their skills of investigation and analysis, and certainly coverage and policy evaluations are important, all while still balancing the need to be empathetic and caring and understanding, specifically on the work comp side. What we've been doing really to support our claim staff with this just flood of information is to take information as we receive it and dissect it and to do an analysis. And then we're doing state roundtables where we are including attorneys where it's needed to really give us maybe a broad understanding of the legal implications and case law. We are collecting all of this information. We've created an internal SharePoint by state where we document the analysis of the changes by both state and by line of insurance. We are doing a number of case-by-case consultations with our case manager, especially if we have a case that we have determined compensable, so that we can do a full analysis of the medical component, which again is rapidly developing, to talk about treatments, periods of disability, and certainly working through keeping the injured worker engaged so that we don't see or we recognize any secondary treatment needs, again, that may involve mental health. Certainly for the non-COVID claims, and remember, there was this huge bulk of files that were in existence when COVID-19 claims became apparent or surfaced. And it is so important to continue to work on those claims and to actively engage injured workers. We need to ensure that there is continuity of care. The continuation of medical treatment, while it is challenging, and I will tell you it has been challenging, is certainly not impossible. There are many solutions available. We've been certainly lucky enough to have utilized telehealth for several years as part of our new loss intake process, and some of you may be familiar with that, where we have virtual occupational clinic available as part of our model. What we've done now is really expand our telehealth options to include what we're calling a direct-to-telehealth, which is the ability to direct existing claims to virtual treatment options or opportunities. So we're working with our case managers, our adjusters and our case managers are working very quickly to try and transition as many injured workers as we can to virtual or other telehealth treatment options. We've seen a very strong acceptance of telehealth by injured workers. And I will say the one thing that COVID-19 has really done for us is challenge us to look at different solutions and ideas to ensure continuity of care and continuity of benefits. And I think as this dynamic of COVID-19 continues to develop, one of the real positives that we will see is really the broad adoption and the recognition and the value of telehealth and virtual care options. To support this, we did a mass mailing of letters to injured workers and counsel, if they had counsel, sort of outlining treatment options that may be available to them. And then subsequent to that, our claims handlers and our case managers actively have been reaching out to injured workers, one, to provide, again, engagement and reassurance in regards to their claim, ongoing benefits, and certainly the partnership of us supporting them from an advocacy situation. And we also want to talk about treatment options. Let's get them transferred over in cases where it is possible to take advantage of virtual care options, again, so that we avoid an interruption of care and we can keep their claim moving and keep the injured worker engaged. And so we've had some great success. I'm really proud of the work that's being done by our claims handlers in that regard. So we know this is really an ever-changing, evergreen situation. Communication remains vital. Certainly at Corvell, we're very fortunate enough to have not only claims, but really broad clinical resources that support us all as we deal with these concerning claims. So I'd like to pass this over now to Karen Thomas, and she's going to share the clinical perspective of what we're seeing with COVID-19. Karen?
Thank you so much, Michelle. So it's important to understand this virus is nothing like influenza, and it's very different than other coronaviruses. Complications and deaths are not due to virus, they're actually due to the body's immune response. And 15% of individuals who test positive experience severe symptoms, and 5% experience critical symptoms, meaning they land in critical care units for support. And these severe or critical symptoms can lead to long-term debilitative effects. So age, underlying illness, gender, and race make individuals more prone to suffer the more severe symptoms. And we know now through research over the last few weeks that older people, men, African Americans, and people who suffer autoimmune issues are at greater risk to develop complications from COVID. For younger people severely affected by COVID, increasing research is showing genetics, underlying autoimmune and medical issues that maybe weren't detected previously are causing severe reactions to the virus. The leading complication and cause of death with COVID is acute respiratory distress syndrome, otherwise known as ARDS. This occurs when fluid builds up in the tiny air sacs in the lungs. Less oxygen is provided to organs, which typically causes the body to work harder to breathe. What's interesting with COVID is that we see the very low oxygen saturation rate, but not the increased work to breathe. So people aren't experiencing that feeling of breathlessness. And this is why you hear stories of seemingly healthy people who have been diagnosed with COVID. They seem to be recovering, and then all of a sudden they're just dropping without forewarning. That's also kind of causing physicians to question the use of intubation, that mechanical support. The second biggest complication is cardiovascular issues. We're seeing infections in the heart muscle and lining, heart failure, arrhythmias, and heart damage due to medications. The third biggest complication is blood clotting issues. So physicians aren't sure if the blood complications are due to the direct assault on blood vessels or a hyperactive inflammatory response to the virus by the immune system. The body's developing microclots with the COVID virus that cause stroke, liver and kidney failure, even tissue death, which requires amputation of limbs. Nick Cordero, a Broadway star, pretty prominent Broadway star, had his leg amputated last week, most unfortunately, and continues to fight for his life. There's a new phenomenon of young people in their 30s and 40s having major strokes, leaving them majorly debilitated. Researchers are suspecting that the strokes in the COVID-19 patients may be a direct consequence of clotting issues. So the number of those affected are small, but it is remarkable because it's challenging how physicians understand the virus. We're also beginning to see post-intensive care syndrome. This is kind of a combination of symptoms that happen when people come out of critical care units. That can include muscle weakness, cognitive or brain dysfunction, and other health problems as people recover from the stays in these critical care units. For the 80% of the patients who test COVID positive and experience mild to no symptoms, our nurses are really seeing widespread indications of mild to severe anxiety. And we know that untreated anxiety can lead to post-traumatic stress disorder. Michelle mentioned that we're starting to see these types of claims, particularly, of course, with our first responders and healthcare workers. So how are we caring for our COVID patients? So Korbel has developed COVID-19 specific protocols based on CDC WHO guidelines that guide holistic care. The first thing that our nurses are doing are documenting a 911 plan to help people be prepared. So we know that first responders are struggling in certain pockets across the country. Continuity of care has been disrupted with providers. So it's critical that we have our injured workers, all patients, all people really, ensuring that we've got a plan in place if illness escalates. And not only do we have a plan, we have a backup plan and then a backup to the backup plan. We're performing wellness checks. We understand that symptoms are highly individualistic. Severity can vary as well. So we're evaluating our injured workers every 24 to 48 hours, and we're certainly educating our injured workers on how to escalate care and take care of themselves and their families. We also understand that the virus can change at about the 7-day mark, so people who are seemingly recovering can suddenly and very rapidly become ill. This is likely related to the overreaction of the body's immune response. And we want people to understand that most of the severe complications can be treated. So it's imperative for ill people to understand that early response is critical. So this isn't the type of virus that we want people to tough out. We certainly impress upon all of our patients the criticalness of getting help immediately for all of these COVID symptoms. Michelle talked about the virtual visits to stay connected. When we have injured worker permission, we're connecting nurses via video chats. This is really helping the nurses to lay eyes on people. It helps alleviate anxiety. And certainly the platform that we're using is compliant with Department of Health and Human Service guidelines and is HIPAA compliant. And then we're also ensuring that we're addressing the emotional toll. This virus really has an interesting emotional connection to people. I think based on, how fast supposedly it came along and how severe the symptomatology can be and develop. We know that certainly the deepest trauma surfaces only after the initial threat has ended, and anxiety is going to linger for a lot of the population that both has had COVID and hasn't had COVID. So we're using tools to assess attitudes, beliefs, keeping emotional health kind of at the forefront. We use a risk recovery questionnaire. We're constantly evaluating for those signs of anxiety and depression. We want to head off trouble before it becomes trouble. And we're certainly kind of partnering with employers to point people to their EAP programs. And we do have cognitive behavior therapy available via telemedicine if that's necessary or needed. So Michelle mentioned the importance of not leaving our injured population who has not been directly affected by COVID-19 behind. We want to make sure that for our injured workers that have suffered injuries on the job or illness, that we're keeping the recovery moving forward. So we are encouraging the embracing of this virtual world, and honestly, that hasn't taken a lot of prompting for sure. So we've got the virtual visits that nurses are providing, and certainly telemedicine. We're facilitating that communication between providers. We offer the direct connect to telemedicine physicians. So if an injured worker can't be treated by telemedicine via their treating physician, or perhaps they're not comfortable going into brick and mortar, we can connect them with an occupational health specialist and include their treating physician so that care isn't disrupted, and we provide continuity there. We're about to roll out an app for our injured workers to use for pre-surgical candidates and injured workers with back pain. The app provides an interactive platform and enables education on nutrition, physical therapy, pain, anxiety management, environmental safety, and health literacy. So this just makes sure that we're using best use of time as we're waiting for elective surgeries to begin again. Injured workers are prepared for surgery and then can realize really the best outcome post-op. And then again, making mental health a priority. Obviously, this is a big theme. We can't stress that enough. Combating the isolation. We know that injured workers are at risk anyway for feeling isolated. We help them to recognize signs of stress in themselves and loved ones, and how to relieve that anxiety and manage it. We provide resources. So we stress the importance of overall health. Now is not the time to have anyone have to go to a hospital. So we're making sure that we're evaluating and assessing and educating and helping in that regard. And finally, we're making sure to connect with employers. We're keeping them in the loop, and we're assisting with return to work in this new COVID world. So real briefly to kind of change the focus, what are we doing at CoreVal to keep our folks engaged and supported? So, our claim professionals, our clinical teams are dealing with frontline workers who are suffering a lot of trauma, and that can be very wearing on a day-to-day basis. So we're working hard to provide our clinicians with accurate information from credible, reliable sources. Michelle talked about kind of gleaning the information so that they're not overwhelmed and they're operating with the most current data. CDC just updated their symptom list Monday. So, we had education go out to all of our nurses about that and updated their assessment tools. We're promoting pro-social behavior. We know that humans thrive when they cooperate with biggest groups. We learned that from the cavemen, certainly. So we're seeing kind of that survival instincts reemerging, and we know that the greatest psychosocial shift in mid-crisis occurs when pro-social behavior is embraced. So we're really leaning on each other. That's certainly our culture here at Corval. We embrace the team, and we're very fortunate to have both that claim perspective and clinical perspective to help each other through. And we keep it light. Stories of virtual team building, conference call bingo, random meal delivery is occurring to provide positive support. And I'm sure all of you have participated in virtual Zoom happy hours after work to keep morale high. Our managers are providing one-on-one weekly meetings with their direct reports to provide support and help these clinicians understand that there's little control over so many forces, but to continue to engage and take care of themselves first so they can be good care providers is really critical. And we understand that resilience comes through acceptance, and certainly liberation comes through acceptance. So when are we going to see the light at the end of the tunnel? So first, COVID testing needs to generate sufficient data to guide response. It really all comes down to wide-scale testing. And we are beginning to see this in pockets across the country. Serology testing confirms that more people have had the virus. So there was a recent study in Santa Clara that suggested 40 to 80 times more people have had the virus. And this is certainly good news, as it means that we are further along in the pandemic than originally thought. And this month, New York has started random testing on grocery store patrons in different regions, and New York's goal is 30 tests per 1,000, and that's really going to help in this identification of antibodies. So we need to see health data show symptoms are decreasing, and we need to see that healthcare systems are prepared. So we have certainly seen in New York that the healthcare system has bent unbelievably, but it hasn't broken. And that's very, very hopeful news. So we're going to need to see evidence from other geographic areas that have yet to experience peak activity to ensure that we have enough critical care beds, ventilators, personal protective equipment, and staffing. And then we also need to be able to see that rural communities are handling the challenge of COVID. So typically rural healthcare systems are smaller and more isolated, and rural populations tend to be poorer and more prone to underlying conditions that can make the COVID-19 complications more lethal. And then finally, we have to commit to social distance and excellent hygiene. Until we experience herd immunity or the implementation of vaccine, we have to exercise extreme caution. Certainly how we behave is going to determine how big this virus is going to get. And with that, it is time for some Q&A.
Thank you, Karen, Michelle, and Dave, for your presentation. Now I'd like to invite Diane to submit any questions that we might have received from the audience.
Absolutely, thank you, and thank you to all our speakers. First question goes out to Michelle Tucker. We are looking at potentially a presumption any day in California. We can be fairly certain that this will happen. How does Corvell anticipate claim handling and investigation will change when that does happen, Michelle?
Sure, thank you for the question, and I agree. Like many of you, I'm surprised we don't already have something in California, but I would expect it at any moment. I think the first thing we need to know is, what does the legislation say? The current version is very different than, of course, the original version, and it is being changed. So looking at what the presumption states, the nature of the presumption, is it conclusive or rebuttable, and who specifically it covers. Does it cover only certain species of employees, or is it more broad in regards to essential employees? And we will do very similarly to what we've done across the country, which is an analysis of the legislation as to how it applies and what questions will be important and what pieces of information will be important to collect in regards to addressing the applicability of the presumption to each case-by-case situation. Thank you, Diane.
Great, thank you. Thank you, Michelle. This one's for Karen. Karen, can you provide more information on the app for the pre-surgical and back pain patients that you referred to? And will there be any promotional materials for it?
Oh, indeed there will. So information coming very soon. We're actively working on that now. The app is in conjunction with our business partner, PeerWell. So look for that very, very shortly in the next week.
Sounds great. Thank you, Karen. It does sound very exciting. This one's for Dave Brown. Dave, for companies that are still having workers in manufacturing plants, do you recommend that a claim is turned in only when an employee alleges that they got COVID at work, or for any employees who contract COVID as a notice only?
Yes, I think it's a very wise idea in most cases to turn in the notice only if someone's contracted COVID. I think even more importantly, to be sure that you know how you can prove that it did not happen at work. So if you have an employee that has not clearly alleged that it happened outside of work, I'd be careful about turning it in as a notice only. It should be fully investigated to avoid later questions of late reporting. But getting the notice over for those that are not work related will also help to show your due diligence and being fully transparent about the cases that you have.
Great, thank you, Dave. So err on the side of caution and report, correct?
Correct. Thank you, Diane.
Another question from Michelle Tucker. So Michelle, what about the population that is not involved in the healthcare business? Grocery chains, for example. How do you measure compensability or determine with employees?
Good question. And I would say, for starters, depends on the state where it happens, because again, we've seen some expansion of presumptions to include essential workers, which would include in some situations grocery, retail workers, delivery drivers, those kinds of things. So I think first and foremost, we really have to look at what applies jurisdictionally for that state. And it would be very similar to, again, building up and determining the threshold of risk. Broadly, there's been a question, is a grocery worker at a higher level of risk as an essential worker than the general public? Again, thorough analysis, collecting, again, when they've been at work. We talked about the timeline of development in regards to symptomology. We'll ask about PPE, certainly cautiously. And then I think really once all of that information is collected, having a good conversation with the employer, and again, perhaps counsel, and if there's a carrier involved, to talk about the threshold of risk, if that's what applies in that particular jurisdiction. So if it's an occupational disease, there's not been clarity in regards to presumptions, then what is the level of risk that they've been exposed to, and does it meet the threshold for occupational disease or not, in some analysis of the case law. So very individual situation, again, difficult to ascertain, and it does require very broad, in-depth investigation, very case by case.
Great, thank you, Michelle. Our clinical question for you, Karen, and I think this is kind of putting you a little bit on the spot, but can you comment on any new treatment modalities, medications in the treatment of COVID-19 critical patients?
Yeah, a little bit on the spot. So those are changing daily. Really exciting things coming out from the hospitals in particular in New York. So you've heard about the plasma treatments that are showing promise. Certain drugs, without naming specifics, trials are happening. I would say another silver lining from COVID is this really rapid research that's occurring and the sharing of information internationally. Um, so certainly use of positioning as opposed to ventilators. I mentioned the concern there. Um, so yeah, look for things to come daily as this has turned out, and it's been an incredible time in the scientific community as everyone has come together and is sharing these treatment modalities that they're putting into practice almost immediately with evidence.
Thanks for your response, Karen. And I know we did put you on the spot. We do appreciate your clinical expertise, and we know that you're keeping an eye on everything as it comes through daily. So thank you. Another question for Dave. Dave, outside of first responders, are you seeing work comp claims coming from general manufacturing, those in the essential business? Are you expecting an increase as time goes on?
We are beginning to see a little bit of a ramp up in manufacturing. That's definitely the smallest portion of the claims we've received so far. But the trending continues to be interesting as we think we're ramping up in a state and then ramping back down. It'll start again with another industry, another occupation, and manufacturing is on the rise.
Thank you, Dave. Let's go back over to Michelle here for the next question. Does having employees working at a hospital who do not have a specific exposure automatically make it compensable for that employee?
Well, thank you for the question. Again, I will defer initially back to the jurisdictional rules regarding presumptions. Many of the presumptions are rebuttable. I will say anecdotally and professionally, I think you're going to have a difficult time with rebutting that, even if there's not specific exposure. In most healthcare environments, as you can imagine, at any time someone may have COVID or expose someone to COVID without knowing, even without symptoms. So I think, again, working on the timeline of the development of symptoms, certainly you don't know necessarily when the exposure is, but if they've worked in that period of time, and again, depending on the jurisdictional requirements or conditions of compensability, again, I think that's going to be a tough road to overcome in regards to compensability.
Thank you, Michelle. Another clinical question for you, Karen. Hopefully this is not going to put you on the spot. Is COVID-19 a respiratory illness?
Yeah, so it's a virus, and it causes response in the respiratory system, along with the other complications I mentioned. So at its heart, it is a virus, and it causes certainly the symptomatology that you see that causes upper respiratory response.
Thanks, Karen. And another question for Dave. Dave, have we received any claims from school districts?
We have. I'm going to see if I can get a relative percentage here in a minute. As I saw the question, I was just starting to look for it, Diane, but we are seeing, as a result of the public entity business, we have quite a few school systems within public entities and standalone. So yes, we're seeing a fair representation in that industry category.
Thank you, Dave. And we're really at the top of the hour, so a lot of questions still left unanswered. I'll ask you to refer or reach out to your Corvell rep, and hopefully we can get all of your questions answered. Back to you, Matt.
Thank you, Diane. And thank you very much for monitoring and posing the questions to our panelists. I'd like to thank all of our panelists today, Dave, Michelle, and Karen, for your excellent information and presentation today. And thank you to all of you for your attendance and attention today. And thank you for all of the great questions. You'll be directed to a survey as you leave the event, and we'd love to get your feedback on any topics that would interest you for future webinars. And stay tuned, we'll be releasing information about a future webinar in May. The topic and dates are to be determined, but we'll be sending out information about the next webinar we'll be presenting in May very soon. So once again, thank you all for joining the call today, and we wish you a very pleasant rest of your day. Stay well.